Hello, everyone. This is Dr. Tony. Today, I'd like to talk to you about problem patients that you would have, either in group or in individual therapy. Okay. A lot of my material is taken from Irvin Yalom, who, in my opinion, is the guru of group therapy. He has several books out, and one of them is entitled The Theory and Practice of Group Psychotherapy. The Theory and Practice of Group Psychotherapy by Irvin Yalom. Okay. It's a great resource. It's a good book to have in your library if you don't have it. Um, Pick it up. You can get it on Amazon or any other bookstore. Look for a used one. It's really good. So he talks a little bit about this. So I'd like to start with what we call in the group the monopolist. Now, the monopolist is a person that just chatters incessantly in group, just will not shut up. Okay. Um, and if we have this person that just keeps talking and talking and talking, and you notice it, you're going to have to put boundaries on that individual. You're going to have to tell them in some way, you got to be very patient, but you got to tell them in some way that there's other people in the group. Or if you're in an individual session, you know, uh, you can either let them ramble on and you'll get nothing done in session, or you quiet them down, use your body language, put your hand out, hold on just for a second, type thing. And let me just summarize what you said and then continue on from there. In group, you may have to do the same thing. There's more people in the group than you, Johnny. Could you just hold on for just a second? I would put it that way because that could be seen as hostile, and you don't want to do that. But in some way, put the boundaries there. All right. If you know this person does this, and all of a sudden they become very quiet, okay, in group, there's something wrong. They could be anxious. That's a big thing. And it's a different type of anxiety because sometimes the monopolists, the reason why they are the monopolists and they chatter is due to anxiety. So anxiety will get them to talk. Anxiety will also get them to be quiet. And there's also other things going on that we'll talk about later on in here. Like when they become a narcissist, and you have this monopolist that's also a narcissist. But you'll connect them when I talk about that. Okay. The other thing you want to watch out for is when the monopolist gets the floor or somebody else gets the floor and they want to talk. Or if you're in session with them individually and you want to interject, all right, you got to be very careful because what will happen is if you're in group, the person that's talking has a brief period of silence after they've shared, right? Monopolist is going to jump right in, especially if the person turns around and they have an issue. What the monopolist will do is the monopolist will turn around and sit there, and even if they never had that issue, they'll say that they did, and then they're off to the races talking about it. And that has to stop. Okay. Um, they'll continually address the problems over and over and over. In other words, we call this hijacking the group. And this can be a real problem. So part of their hijacking is when somebody starts to share, and you know how you ask questions, or people that are in the group want to share their own stuff or want to interact with the individual. Well, they'll interact all right. They'll interrogate the person. It's like the Spanish Inquisition, you know. They'll say something. The person that's sharing will say something, and then all of a sudden they'll pause for a moment to get a thought, and all of a sudden, right as they pause, the monopolist is going to jump in there and they're going to start to interrogate the person. Something like, so when did this happen to you? How often does this happen to you? Where did it happen? Who were you with? Were you with anybody? Did you use? Did you not use? What's going? And they'll just keep going. Okay. They will barrage the group with questions like you just don't know. And they'll get there and they'll make observations of the group. So as they're barraging with questions, they're looking around. It's almost like an anxious staring. They're just doing this all day long within the group. And if somebody sits there and just goes like this, they'll just jump on that person, sit there and say, well, Billy, what about you? I mean, look, you're hearing this person talking and you're looking down like that. What's going on? Are you okay? Uh, you got to be careful because sometimes hostility breeds hostility in the group. So if they attack somebody like that, or they try to bring somebody into the group like that, they may get attacked. And if the monopolist gets attacked by somebody else for what they say or how they say it, that's just going to bring hostility. So you're going to have an out of control group in a flash. Okay. If you have somebody that is emotional in group, we call this a lay-by-la effect. They're crying, they're kind of looking like this, right? Or they're anxious and they're kind of like clenching their teeth and their pressured speech, that type of thing. Okay. Or they start to cry again, or they laugh, appropriately or inappropriately, whatever it may be. Okay. Um, the monopolist will jump right in on that as well. And they will do it with a flare. They will just sit there and they if the person's crying, they may just immediately join in with the client, and they may start, oh, the same thing happened to me, and then they'll start crying. And or if the person starts talking with a pressured speech, they'll sit there, and the anxiety within them will get moving to the point where they're going to start to talk with a type of pressured speech. Okay. Um, in other words, if the person is having a crisis in a group, not the monopolist, but if there's a person in the group that's having a crisis, the monopolist will jump right in there and either exacerbate the crisis or sit there and talk about their own crisis. That looks like it. So with the monopolist, you got to be very careful, and you have to be able to hold the boundary on that person because they have an effect on the group. They actually do. I mean, the initial welcoming could be a very nice welcoming with the person. They'll listen to everybody, and then when it's their time, to share, they won't shut up. They'll tell you their life story from childhood. If you're going around the group, and let's say the person's in the middle or towards the end, something like that, they may sit there and may even say, "Could you come back to me? I need to think about that for a little bit." I mean, I just would like to share a few things, but later. And you being a group leader will say, sure, because you never want to pressure somebody. And then after everybody is done and you come back to that person, that's where they start to rev up. Oh, let me tell you about me. Well, I heard Johnny say this and Kathy say this and Marty say this and Mary say this. And well, I can relate to all of them because in my childhood, this is what happened to me. And then that's it, they're off. Okay. If they're in group and you're sharing and things are going well in the process, and the monopolist may or may not be sitting there in silence, and sometimes the silence may not be anxiety, but the silence could be observation to see who's going to be most vulnerable and who they can you jump on, or who they can emulate, that type of thing. So as people are talking and the monopolist comes in, some people will sit there and they'll interject. Some of the more affluent group members will interject and stop them and say, look, I got something to say too. Let me say it. But others will not say anything. Those are the ones that we'll talk about in a little bit, called the silent patient. These patients will hide. These patients will just sit there in group and just thank God they've got a monopolist, because that way they don't have to say a thing. And if they don't have to say a thing, they're very safe, right? And that's what you don't want in a group. Of course, you want a safe group, but you want the people not to be in their comfort zone. You want them out of their comfort zone. And if their comfort zone is quiet, then they're taking everything that is being said and they're just embodying it. And that's not good. Monopolists may attack group members obliquely off to the side. Oh, you think you're tough? You're not tough. I've been in that situation too, and let me tell you what it's been like. They can attack them that way. Oh, you think you went through it? Well, let me tell you what I went through. Right? What you're going through is nothing. Or maybe something like, yeah, you were sick. Everybody gets sick. I mean, if you're coming off of heroin, you're gonna throw your guts up. I did, right? So you got to be careful with that because that could be seen as hostility. And then once that happens, the group can become hostile. Or if the group isn't hostile, the group member that's sharing will become very silent and you won't see them again because they don't feel safe in the group. So the monopolist is a very controlling person, and in fact, the monopolist will even try to take your spot as the group leader. So the anxiety and pathology that we see, right, becomes what we call a folie à deux, which is a shared psychosis. So as a monopolist is in their anxious, talkative mode, right, and they start connecting with other people, and you all of a sudden you start to pick up a pattern that the monopolist has had every illness that you see in the group because they address every client and they personalize it. They share that belief system that, even if a person sits there and says, I've heard voices, when I was coming down, they're going to sit there and say, I did too, and this is what mine said. Sounds like yours, doesn't it? Right. Or they can actually mirror the patient week after week after week, and you'll see the monopolist get sicker and sicker. That's called a folie à deux. Okay, this is because of some unresolved tensions that the monopolist has. Right, it could be from childhood all the way up to the present day. That's why they're sitting there with you. So these unresolved tensions that they have become very problematic, in the group. And what that can do is that can just superimpose on the other patients in the group their problems, which makes their problems feel totally impossible because they're not being heard because the monopolist is taking over. If that happens, you've lost the group. You will see members dropping like flies. This is why monopolists have to be kept under control, not disrespected, but you have to learn how to put boundaries on people. The best way to do that is to talk to your supervisor or to ask for supervision on this because every monopolist is different. I can't tell you how to, cap a monopolist. I got to see it right in front of you. Okay. But you can't leave it alone. Confrontation of a monopolist with group members, if you're not careful, can be, as I said, explosive. They can blow up in the monopolist's face. And if that happens, then all of a sudden you'll see this very bubbly, overpowering person start to become very emotional. Their affect will become labile and they'll start to sulk. Oh, you just don't want to listen to me. Nobody wants to hear me. I've got these serious problems. They're so terrible. Screw this group, blah, 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 blah. And they'll leave the group. They may leave the group right there. Now, if anybody, not just a monopolist, but anybody leaves a group, the only thing you can do as they're walking out the room is ask them to please sit down and return. Do not get out of your seat. Do not go after the patient. That will destroy the group. Let the person leave and then process that leave in group. If there's a way that you can access another therapist or if you're in a clinic and there's security, just make sure that you let them know if so-and-so walks out or if anybody walks out of my group, just watch them. Because the thing you want to do is safety, because some of these folks will be suicidal. They may walk out of the group. Now, if you do have a suicidal patient and they walk out of group and huff because this monopolist or somebody took over, that's one of the few times you get out of your seat, tell the group to sit there and wait, and you go after the person. Do not touch them. Go after the person, try to coax them back in group. If they walk out of the clinic, you need to call 911 and have that person picked up and taken to an emergency room. Because if they commit suicide, that's a liability. Okay. So these are some things with the monopolist that you want to try to watch. So some of the things you also want to consider with the monopolist, right? Because these people are going to be very agitating. Don't shout at them. It's going to feel really good to shout at them but contain yourself. Don't shout at them, okay? Um, because all that will do is that will cause anxiety within the group. The monopolist will turn on you and will sit there and say things like, but you're the therapist. What's the matter? Don't you understand? I'm a sick person and you're yelling at me. What am I doing in this group? And now all of a sudden, again, they're off to the races, and other group members are going to see that, and they're going to start to think, well, if he's yelling at this one, should I share? Because if I say something and I go a little bit longer than ever, is Doc going to yell at me too? Don't. Okay. Be very patient. Don't wait for the group to handle the monopolist either. Okay, you've got to handle it. Sometimes group members will step in. That's great. Let them step in. Let them, see what they do. But it's not the group member's job to handle the monopolist. It's your job. You need to find a way to do this. Yalom's got many suggestions in his book. That's why I'm saying look at it and read it. From the group standpoint, you got to understand as a therapist that a monopolist does not exist in a vacuum. It's not just me, 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 me. Okay, you've got people in a group or even in individual sessions. There's some type of external stimulus that's setting this monopolist off. Either something, if you're in an individual group that you've said that you've brought up, that all of a sudden the monopolist turns around and says, hey, look, this is what's happening. Or it could be something that a group member is bringing up. If it's something a group member is bringing up, then we have a dynamic going in group, and you can use that. But don't ever think that it's just this person's problem. It's not this person's problem only, because something was surfaced from them, from other people in group to them. So as if you're in group, okay, the group members at a later time, let's say if the person leaves, or even if the person is in there and you've got them contained, this has to be addressed. Not immediately necessarily, but at a later time throughout the group process, however long you have it, this needs to be discussed, because some members are going to be very inactive, some members are not going to talk, some members are going to shut down. You need to address that. Some are going to be over boisterous, some of them are going to be very angry and yelling at the person. You got to address that. Now, another thing that's very interesting about the dynamic of the monopolist in a group is that the group may enjoy the monopolist. They may. They may absolutely enjoy it, and that's a problem as well. Because what the monopolist will do is, the group will sit there and they'll listen carefully to what they have to say, and they'll victimize the monopolist's plight. And the monopolist will victimize the other patient's plight. And they'll play a game. One up or one down. And this can go on for sessions if it's not stopped. So they figure, well, what the heck? This guy's over here talking, he thinks he's doing something. I wonder why. So what the heck? I'm gonna give it back to him. Try not to let that happen. So your approach should be to work personally outside of the group process, because sometimes what may happen is you may have to discharge the person from group, not the clinic, from group, and handle them in session. If you can't handle them in session, you may need to discharge them from group and refer them to another therapist that can handle them in session. Okay, so if that happens, then the person will be taken care of either by you or by somebody else. So you need to discern the behavior, if possible, at the interview, when you interview somebody for a group and even for individual session as you're doing your psychosocials. Okay, if you find this person, just can't shut up and just wants to overtake everything, their ego is a lot more than what should be handled. Well, there's an issue with that, right? You discern that. Don't put that person in group. I know with Medi-Cal and Medi-Cal regulations, which are all messed up, everybody has to go to group. Well, what Medi-Cal doesn't understand or doesn't want to understand is that some people are not group ready. A monopolist is not group ready. That will destroy a group. Understand the behavior is one of controlling others. It is not simply because they are anxious. Now, that pathology of monopolists controlling others is long-standing. It just doesn't happen overnight. They can be having what we call reaction formation. They can be reacting to somebody from childhood that controlled them. And they were angry at them, but couldn't express their anger. So because they were controlled, could not express their anger, were sequestered in their thought processes and their speech, they themselves become anxious and bury their anger, bury their feelings. So then as time goes on, now they have a forum, either with children or peers or something like that, where they see themselves as superior. What happens with that is now they start to try to control others, and they will do everything they can to get the attention and to control. That's a monopolist, because just like they couldn't say anything, they're going to make sure you can't say anything. And they're going to have the power that was thwarted on them in the back. So you want to teach the monopolist, when you see this behavior, to be able to receive feedback safely. So in your sessions, play a game. I want you to do something for me, okay? I want you to say something. I want you to present a real small, and you can even have this written down in the script. I want you to take this script and I want you to read this for me, okay? And then I want you to say something, line one, and then I'm going to respond to it. I'm going to give you feedback on it. All right. And only stay to the script. Don't give me any more, because I'll stop you. Because what will happen if you script the behavior like that, kind of like a play or something, whatever you want to do, it's up to you. As you give the feedback, the monopolist will read what's on the paper, and then all of a sudden they'll sit there and say, and also, that's when you stop it. And say, no, let's move on to the next one. And you keep doing this. And then you remove the script and you say, okay, talk to me about an issue, and I'm going to give you some feedback on it. I'm going to do the same thing we do with the script, remember? So I'm going to stop you if you start going off. And you do this until all of a sudden the monopolist starts to give and take relationship, where you can now talk to the individual, give feedback to the individual, and they're not going to try to take over. So it decreases the anxiety, it decreases the ego mechanisms, it decreases the reaction formation. And what you do during that process is you give constructive feedback across the board. Not just, oh, wow, that's really a good job you did, but tell them, this is the reason why I think it's a good job, right? This is what I see in the past, and this is what I see now. Give them that feedback, because the more feedback that you give them, the better it's going to be, okay? All right, let's move on to the second type of person, called the silent patient, okay? Now, the silent patient in a group is a lot less disruptive than the monopolist. Totally, right? But they're just as challenging. Now, we as therapists, sometimes if we have a group, sometimes if it's an active group, we just love the silent patient, because it's like, thank God somebody's not saying a word. Or if you're a lazy therapist and you have no idea what the heck you're doing, and you got 50 minutes with a group, you hope that you have silent patients, so that the ones that do talk just take over the group and monopolize the group, and the silent patient doesn't say a thing, so you don't have to deal with their issues. And what are you working there for, right? But the silent client that you have is a dangerous one, because they're taking everything in. And some of the things you may hear from the silent client as you go around, let's say, for example, Jack over here, okay, is a silent client. And, the group has been going on for about 15 minutes and Jack hasn't said a thing. So then all of a sudden there's a lull, and you sit there and say, Jack, noticing you're kind of quiet. Is there anything you want to say? And Jack will sit there and say, "Oh no, 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 that's okay. I'm fine right now. I'm fine. I'm listening to everybody and I'm soaking it in. Yeah, I'm getting a lot out of this." Um, and you'll sit there like the good therapist and say, "Well, okay, I'll give you your space. It's fine, Jack. I'll come back to you. But if you want to chime in, chime in. Okay, great." And you move on. Be careful of that. Because that was just that guy didn't ask me any more questions, right? If you see a pattern like that, that needs to be addressed either in group or out of group. If it's done in group, you got to be careful because if you do have a silent patient and you don't know the etiology of the silence, what that can do is that can further the silence on that patient. And if it does further the silence on that patient, now we have another issue involved. Okay. So they're less disruptive, they're nice, they're kind, they're sweet, they're the prize patient, but they can be dangerous because the silent client could be harboring all kinds of stuff, including suicidal ideations, homicidal ideations, homicidal thoughts, suicidal thoughts. Some may benefit greatly, however, you got to understand that too, by just sitting there in silence. Others, as they sit in silence, will decompensate. They may start to cry. They may start to laugh inappropriately. They may start, and you'll see that. They may start looking around the room at the corners, and all of a sudden you'll see their affect changes, returning to responding to internal stimuli or external stimuli that they're seeing, seeing things, hearing voices, that type of thing. They may get lost in the crowd. In other words, as people are talking, they may just do absolutely nothing and just get lost. And I don't know what's going on in this group. I don't know why I'm here. So I'm just going to be quiet. That can be a real big problem. Silent clients very rarely benefit significantly in group unless you can break them out of that silence. So if again, we go back to the basics, we go back to the psychosocial, the interview. If you're going through an interview and you find that this person is a very silent person, or they may not be silent in an interview that you're doing, but all of a sudden you put them in group and all of a sudden it's like, this is a different person, you have to pull them out of group. Now, that doesn't mean that they'll never be ready for group. What that means is you have to get them ready for group. So when you're dealing with a silent patient, this is something you want to think about. So the more you have them ready and the more you get them ready for group, the better it's going to be for them. Because this way, what can happen is the person will then sit there and they'll understand what's happening in group and how group operates and how group works. And then they're going to start to talk to other people as time goes on. What you don't want to do with them is you don't want to necessarily force them. So pull them out of group, talk to them, and integrate them into group. Now, here's something that I've noticed over the years. Silence is never silence. Sometimes a silent patient is writing a book. I don't mean physically writing a book in their head, but their silence tells a story. They could be abused, psychotic, dissociating, anxious, stoned, right? A whole bunch of things. They can be threatened, feel threatened, be threatened, threatening. I had a group one time with a silent patient that had this affect that could look right through his cold as steel. And he used to threaten people. They would be talking, and all of a sudden, something that they would be saying, he would just snap his head and start to look at them and give them this look, and all of a sudden they would just quiet down and not say a thing. And that would be very scary. And because that will do with the person is that will take the person and that will get them to just panic. Not the silent client, but the other person will get them to panic. They'll shut down and they may even leave the group. Now, silence is an interesting thing, and you've got to understand the dynamic of silence. In other words, the talk of silence. You as a therapist, hopefully you're trained, to be silent in group. Don't start sharing your stuff with the patients. I know there are some theorists that sit there and say, well, you need to interact with the patients and share your things. It joins with them. And I see this a lot in the drug and alcohol field. And I am sorry, folks, it is a wrong thing to do. Don't start sharing your stuff with the patients in group to join with the patients. And if you do share things with the groups, you've got to be very careful in what you share. Make it short, brief, sweet, to the point, and shut up. If you're running a group and you've done cocaine or you've done alcohol and you're in recovery and somebody starts talking about their feeling, it's going to trigger you. It's going to hit something inside you. I'm sure of that. But don't start sitting there and say, yes, I know exactly what you're saying, because when I was drunk, this is what I used to do. Now you become the patient. Don't do that. Sit in silence, understand the silence. If you've got a client that's silent, you need to understand the dynamic of silence within that patient. This is where individual session comes along. This is where you sit there with the patient and you ask the patient what is happening. I've noticed that you're very silent in group. I want to address that in session right now with you and me. Let's talk about what's happened in your developmental years. What was the first memory that you have about you being silenced, being told you can't share something? Right? I mean, I remember for me, and this is what I mean by sharing things and how quick it has to be, right? I remember for me when I was a child growing up at home, my dad would always tell us children to be seen, not heard. If you're at a party or you're with a group of family, you don't talk. That was my first memory of being silenced. Now, if you take that scenario, let's say a patient says that, right? And that was their first experience. Be anybody, mom, dad, clergyman, school mate, anybody. But if they say that or something similar to that, tell me how you felt. What was that like for you at that point? And let them talk. And sit there and say, tell me what you would have liked to say to that person. That's going to be a very key question. What would you like to say to that person right now? And then let them talk and then sit there. How did that make you feel? Right? And then if they sit there and say, oh, great. It's not great. Are you angry? Are you angry at that person? Yeah. Well, then why don't you say it? Let them express their emotions. Interpret the feeling, the emotion. If you interpret it correctly, they're going to open up and you're going to start to see a well of feelings coming up and they're going to start to have an emotional experience. They're going to have a labile affect. That's okay. It's not pathological. It's not a monopolist. It's not none of that stuff. It's something that needs to go through the process. So understand the dynamic. So what do you do with the silent client if this stuff happens? Well, periodically, if it's in a group process and they're silent, always go back to them. Susie, how you doing? Oh, I'm okay. You want to say anything? No. I'm just listening. It's okay. Yeah. Are you feeling anything right now? No. I'm good. I'm fine. All right. I'm going to give you your space, Susie. Not a problem. But would you mind if I periodically came back to you? Because I think what you have to say is very important, and I would really like to hear from you, but I'm not going to push it, at least not yet. Okay? Have that little smile on your face when you say that. Okay? I'm not going to push it just yet, but I would like to come back to you because I'm concerned, and I think we all are. But it's okay. Is there anything you want to say now? Oh no. Okay. All right. Let's move on. Thanks, by the way. All right, Johnny, you're next. What's up? So just what you're doing there is you're validating the patient's presence in group, and that's extremely important. Okay. So be respectful, allow them to comment, even if it's a brief one, allow them to say what they have to say, move on. And then take them out of group afterwards, at the end of group. Hey, Susie, can I see you just for a few minutes? You're fine. Just, and then sit them down. Hey, tell me, how was that for you today? was that okay what I did? Because I don't want to put you on the spot. I just want to make you part of the group because I'm noticing that you know you're very, in my opinion, Susie, you're a very integral part of this group, and not hearing you share, I mean, you're depriving a lot of folks of your wisdom, and I want you to get the best help that you can. Are you okay? Yeah. All right. That's what I wanted to say. I just want to make sure we're cool. I just want to make sure that you're not feeling attacked by me. Okay, good. Hey, have a great day. All right. See you next week. Done. You affirmed, you validated, you shared, you listened briefly, and you didn't hold them hostage. You let them go. They come back next week. You're going to start to see the silent client still be silent, but opening up a little bit more until gradually they'll become a group member. This may take 5, 6, 10 sessions. I don't know. Right? It may take no sessions, which means if after about 3 or 4 sessions the client's not opening up more, pull them out of group and just have them for individual and prep them for it. Right? Don't be afraid in individual sessions or in group sessions to comment on their silent behavior. Do it gently, do it respectfully, validate the silence, show your concern. Right? I also would encourage everybody in that group, or if you're an individual session, to reflect on their own inner silence. This works better in group. And also, well, also with you as a therapist, if you're an individual and you find yourself speechless and not knowing where to go with any patient and you sit in silence. I'm not talking about the silence that you need to sit in so that the person has space to talk. I'm talking about your uncomfortability within you. If you're in group, I want you to start to encourage group members to look at their own inner and outward silence and what that means to them. You can have a whole group on that. If you find yourself in individual therapy feeling this way, you need to take that to supervision or to your own psychologist. And like I tell all my supervisees, one of the things that you need to do if you're going to be a good therapist, you need 3 things, right? Malpractice insurance, a good shrink, and a good supervisor. And you take it to the supervisor or the good therapist that you have and talk about that because you need to explore things in you are being triggered, right? Just don't start unloading in group. If everything fails, and this can happen, if everything fails with the patient and you've tried everything that you can do, it's time to seriously consider moving that patient out of the group altogether. And if you're up against a brick wall, talk to your clinical director about moving that patient to somebody else. And make sure your notes are copious. Make sure they are complete, because if the clinical director is going to take a look at your notes and sit there and say, I need to know that this patient needs to move. It's okay. It doesn't show that you're incompetent as a therapist. In fact, when I run a clinic, in the past, and my therapists have come to me with that, I sat there and I had this discussion. Tell me what you think is going on. Let me see the chart. And I'd be reading their notes as they were talking. I'd sit there and say, okay, this makes a lot of sense. Not a problem. Do you have maybe a clinician you got in mind? So we would switch off that way and we would maybe exchange clients, or, if the other therapist didn't mind having another patient, just toss it over and I would give another patient to that therapist. But that's another story. That's an administrative thing. But never sit there and think I'm going to be berated by my clinical director. If he does that, time for you to go to another job, because that guy's an idiot. Right? I respect a clinician that knows their boundaries and limits. I can't treat every patient, and I'm good at this, but I can't treat every patient. And if I have a patient that I can't treat, you better believe I'm going to transfer that patient to somebody else, right? And if it's an insurance client that I'm doing in private practice and I can't handle, I'm going to call the insurance company and say, I'm going to have to release this patient Do you have another referral that I can give them? And I'm going to give that patient another referral and call the therapist and sit there and say, listen, I've got this patient. They're going to call you for a session. If you need any clinical information, get a release of information, send it to me. This is out of my scope of practice. I can't do it. Right? That's not patient abandonment. If you just sit there and say, I can't treat you, we're done here, goodbye, that's patient abandonment. And you'll learn about that in ethics. But if everything else fails, you may need to consider what to do with that client. You understand? That's very important. It's not only the patient's boundaries, but yours as well. All right, so that's the client that's very silent in group. Let's take a look at another one. Let's take a look at the client that everybody just driven up a wall with. Yalom calls this the boring client or the boring patient. This is the one that has nothing to say. I have nothing to say to anyone. I don't know. I I'm sorry. I can't respond to that. Well, you're sitting in group and you're trying to figure out, well, geez, you're in this group of addicts, mental health people, co-occurring disordered people, and you're in here for a reason. Doesn't anything that anybody says over here, you think in your head, doesn't anything anybody says over here hit you? And the person just is like a blank, like, no, I don't know what's going on. I don't know. Well, hey, Johnny, do you have anything you like to say to Billy over here? I no, thanks for sharing. That's it. You never have anything to say. Or all of a sudden you're sitting there, you're maybe doing a psychoeducational group and you want some interactions with the students. And all of a sudden, you sit there and you start to pick students, how you do that. Oh, I'm going to put you on the spot. Right? And all of a sudden, a person comes up, Billy, what about you? I don't know. I hear you're saying, but it just doesn't make sense to me. Oh, what doesn't make sense? I don't know everything. Wow. Right. Then you have that same person sitting there, and all of a sudden you see their affect drop, and they look very sad and very, disoriented. You're sitting there going like, wow, what have I got in front of me now? And you ask the person gently, trying to join them in the group or outside of group, what's going on? And they'll sit there and they'll look at you with their eyes down and they say something like, I don't know, I just don't feel a member of the group. What does that mean? What do you mean you don't feel a member of the group? Well, nobody ever invites me to share. Well, one thing, if they say that you don't want to say is, well, nobody's inviting you to share because you have nothing to share in a group. When you start to share something in group, people will start to invite you more. Now they're going to start to get defensive. I just don't think this is working for me. I don't want to be here anymore. I'm just going to leave. And now you've got to do a Texas two-step and you got to try to re-engage that person, and you just got yourself tons of trouble and lots of work. No one ever invites me to share. Engage them. If you're doing this in an individual session, or well, let me stop there for a second. Engage them if you're having an individual session. How do you do that? Billy, I understand nobody invites you to share. What do you think that's about? Get some of their feedback. Use your motivational interviewing skills. Well, is there anything you think that you can do to initiate that? Uh, Brainstorm with me. There are no wrong answers here. Let's talk about this. And if they still, hubbity, 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 that type of thing. Well, Billy, what do you think about this? And just throw them a little carrot, short, sweet, and to the point. And then let's try that here in session. All right. Again, role play, very important technique. And then try something else. Now, that's one way. Another way in group is you can sit there and say, well, Billy, I want you to sit next to me in, next group that we have. Why? Am I in trouble? No, you're not in trouble. I want you to sit next to me because I want to support you. Because I'm going to have a group and I think you're going to like this one. And it's between you and me. All right. I'm not going to tell you what it is. I'm going to make it a surprise. Look at my face right now, right? Yeah, that little, yeah. Let's play a game here, right? Type thing. Um, Next group, I'd like to have this group on interacting with other people. How many people here have ever come to the point in their life where they just don't want to share anything? Maybe at an AA meeting, or maybe with family members, maybe here in group, where things either are so personal or something is happening and just don't want to share with anybody. Has anybody ever felt that way? You look around and somebody turns around and says, I do. Okay, tell me about that. What was it like for you? Oh, and as they're talking and you're listening, I hear you. Summarize. So what you're saying is this. Am I right? Mhm, good. Has anybody else felt that way, or somebody else? What's that about? And then you start getting something going about what it's like not to have anything to say to others. And then you tap over and say, hey, Billy, what about you, man? Yeah. Do you ever feel that way? I'm sure you do. Play with them a little bit, toy with them. They'll sit there and go, oh, no, I don't feel that way. Gosh. And then other people will sit there and say, oh, Billy, come on. You're always quiet here. Say something. Come on. Play with them. Because sometimes, if you attack somebody like this, they're going to just shut down a little more. If you play with them a little bit in group, I'm not saying be stupid or, something like that. But if you play with them in group, they may open up. Invite them, right? Invite them to share. Sometimes, if it's a very intense group, um, let's say you're running a group and it comes to the point where the people in groups sit there and say, well, the reason why I'm using is because, let's say it's a trauma group, right? An informed trauma group. And it's one of those tense groups. And they're starting to share their emotions, their affect. They're starting to join with one another. They're starting in group to show that they're not really feeling well. Hmm? And then you look over to the boring client and you want to sit there and say, well, how about you? I don't hear anything from you. Are you okay? Now they may sit there and they may say something just totally either right on target or off the wall. You may get the person's like, I really don't want to talk to anybody in here, because I don't know how to. Every time I interact with somebody, I just don't trust them. Oh, what is that you don't trust? Well, my life has just been a mess. Every time I trust somebody, all they want to do is they just want to use me for sex. And I don't want to talk to anybody in here because, if I start to share, you're going to really see how what's happening to me, and you're going to manipulate me like everybody else. Just leave me alone. Wow. Yeah, that right there is a ton of stuff. Right? But it can go one of two ways. That's either a true statement, and this is where knowing your patients is very important. That could be a very true statement, where now you know how to handle it. If you're in a trauma informed group, right? Uh, or it could be a statement that just pushes everybody away, and it's like, oh, I'm not going to touch him. And now the boring client retreats. Now you can't challenge that in group. You can't sit there and say, well, I think that's a bunch of crap. I don't think that's ever happened to you. Because you do that, you're setting yourself up for liability, number one. Number two, you could just be revealing something in the psychosocial that nobody else needs to know. I had a therapist one time I had to fire because of that. Unfortunately, I also had to, my boss told me, which I don't agree with. My boss told me that, I have to tell him that I fired that person. And the reason for it, because they were afraid of a lawsuit, which was about to happen. So I fired the clinician because he said this. He goes, look, that's not true. You people don't use you for sex. You never mentioned that in your psychosocial. you never talk to me about that. You know, you've been beaten, you've been battered, but nobody ever used you for sex. So don't you can't use that in this group. So now you need to tell me what's going on. You need to tell us what's going on. You know, total disrespect. So be very careful. Take the boring client very seriously, you know, very seriously. Not necessarily for their word or for what they don't say, um, but take them as being problematic. They could come across with a very cheerful affect and sit there and say, you know, I'm really feeling good right now. I really have nothing to say. I want to enjoy the moment. I mean, I just feel great. It's good. Let them have their moment, but always keep in the back of your mind, that inquisitive. Wonder what's happening here. He's boring. He's not saying anything. He's not monopolizing. He's not trying to control, but there's something going on. Okay. They could be like the silent client. And the very silent client, as we know, can be dangerous. They can be monopolizing the group by being boring. Think about that. You got a boring client that's a silent client that's also a monopolist. Trifecta. So this is something that we want to take a look at. It's a highly individualized experience, right? Because their boredom, their shutting down is a very safe place for them to be. You know, you look at the person that lacks spontaneity, doesn't take a risk, avoids any semblance of aggressiveness, any semblance of confrontation. This is called alexithymic or alexithymia, right? And alexithymia is expressively difficult, stemming not only from them being neurotic and being inhibited, but they also may have cognitive deficits that we may or may not recognize in the ability to identify how they communicate feelings. These people may not know how they feel. They may not know how to communicate that feeling. They can be very concrete in their thinking. They can lack images and they can lack imagination. They can lack creativity. They can focus on only what we call operational details. Boom, boom, boom. This is how something works. And if it doesn't work this way, it doesn't matter. They may also be totally inhibited from any type of emotional experiences. And this can be, again, developmental. The alexithymic person has a very closed affect and emotional mode. And it can be from a plethora of things, from a psychosis to abuse to just who they are. Be very careful. It speaks volumes. So, as you've got the boring climate, the boring client in group, what do? Well, you help them understand in some way, shape, or form that their fears are founded in something. They do have fears. They may say, I'm not afraid of anything. But if you dig, you'll find them. And the biggest fear is rejection. A lot of boring clients feel totally rejected. They have in the past. And because they're in a group with people, they feel that if they say anything, they're going to be laughed at. They're going to be belittled. They're going to be rejected. They're going to feel abandoned. Or they may feel that the group or you, if you treat them a certain way, are abandoning them. And that's very dangerous for them because then that turns them inward. And now they have a problem now with possible suicidal ideations. Okay. They mistakenly sometimes will confuse very healthy ways to assert themselves has aggressiveness. So in order for them to assert anything, they'll be aggressive and they'll sit there and say, see, I can say something. Look what I'm saying. But they're really attacking somebody. Sound familiar? Yeah, the monopolist. So, be careful of this person. They can't even acknowledge their own um, desires, their own vitality, their own spontaneity, their own interests in anything. And they may or may not even have an opinion, or they may have too much of an opinion that isolates because they could say something that can tick everybody off. And now all of a sudden everybody becomes quiet. And now they'll sit there. And then you'll finally pull the group together again. And then everybody else will start to share and they'll still sit there. And now they just retreated right back into their boringness and their silence. Right. Or they'll just talk and talk and talk. They'll become the monopolist, the boring monopolist. And as they do this, they're boring everybody else until they get rejected. Then when somebody says something and rejects them, then they want to forestall everything. Right? So if you've got the one that's that's quiet, question them, not as a Spanish Inquisition. You want to do this with everyone. Use a Socratic method. The philosopher Socrates, one of the ways that he used to teach, in fact, his method of teaching was to have a dialogue. He would question his students, they would answer, they would question him, he would answer, and it would go back and forth like that. If you can get a Socratic dialogue going on in your group or even in an individual session, you've got it made. That's what you want. Everybody in their own way is creative. So identify their creativity. It's squelched, it's buried, it's sequestered. Try to pull it out, try to identify it. Try to take a look at the parts that almost seem childlike, right? Infinitesimal, right? Tiny, small, or infantilized, treating them like a child, and they'll respond to that. Look at that. Help them remove those obstructions. Give them a sense of solidarity. Allow them to express themselves freely. That's how they'll grow. Okay? Now, all of these I've talked about so far come down to something that we all have, we all regret that we have in our groups and individual sessions. And this is something that I get questioned on a lot in class and also in the therapeutic milieu. And these are the patients which we call borderline patient, the borderline client. Now, if you find somebody that's a borderline, they can have everything we've talked about so far embedded. They could be the monopolist, they could be the boring client, they could be the silent client, they could be anything, all in one. A borderline patient has this pervasive pattern of being unstable in any type of interpersonal relationship, a relationship with themselves. Their affect is totally out of whack, out of sync. It's very labile, happy, sad, mad, glad, mixed, all over the place. They have a very controlling impulse, very controlling. They can't not control, but they're out of control. And their out of control behavior controls them, right? They function dysfunctionally. I call this the functional dysfunction. So what works for them, but it doesn't work in society. They can be frenetic, very frantic, and they can have frenetic effects to avoid real or abandoned or imagine things that are abandoned within themselves and with others. They can be these are very dangerous people. They can avoid things or they can run to things or they can do both that are harmful to them. They're unstable. They're very intense with interpersonal relationships. And I do mean intense. And usually it's characterized by some type of alterations between something that's very extreme, either negatively or positively, right? Um, they're very idealistic. They will idealize things and they will devalue things in the same sentence. Let me show you how this works. You're a therapist and you've got one of these borderline clients and you don't really realize it. And you're working with them for a few sessions and you're starting to see them improve. And they come to you, man, in the fourth session, and you are the greatest thing in the world. You're mate, and you feel great at the end of the session because they've just complimented you and they're showing you the growth and all this, and you're like, yes, you're really looking good, you're really doing fine. And then the next session, they come later and they sit there and they say, you're the worthless piece of crap. I don't know why I even see you anymore. Who do you think you are? I've been doing so good. And now, this last session, I tried something and I fell flat on my face. You piece of crap. And you're licensed or you're able to do treatment. You should be doing treatment. I'm gonna call the board on you. Wow, totally wipe you out. Very unstable, ups and downs. So their identity is what we call disturbance persistent and markedly disturbed. Disturbance persistent means there's something inside them internally that's constantly troubling them. Everything, even externally, that comes troubles them. They're constantly defensive. And internally, they don't know how to handle this. And the disturbance that they have inside flows outside, and they're all over the place. They are just, they don't know what's up, what's down. They're angry one moment, happy the next moment. I'm not talking about mood swings. I'm not talking about somebody I should say necessarily mood swings, but I'm not talking about somebody that's bipolar. Okay, I'm talking about somebody that may or may not be bipolar, but somebody that, as I said, loves you one minute, hates you the next in the same breath. They're very distorted, very unstable in their self-image, and they're very sense of self. They don't know who they are. They don't like themselves. They like themselves. They're not sure about themselves or anybody else. These are usually victims that are been battered, abused, molested, traumatized. Some of these people are multiple personality disorders. They do not know how to handle any type of emotion. These are the ones that are extremely impulsive to self-damage. You'll see them with cuts on their arm, right? Or they'll sit there and they'll have their sleeves constantly all the way down, all the time, very buttoned up, and they'll hide them. They won't, roll their sleeves up at all because they'll see their cuts. And if you notice it, you'll sit there and say, "Mom, I'm noticing that you have, these marks on your arms. Are you cutting yourself?" And they'll say, "Yeah." And you may ask the question that I really don't like people to ask, well, why are you doing that? Um, you want to ask the question, what's the purpose of you cutting? As opposed to why are you cutting it? Sounds like the same question, but it's not. They may tell you something like, I'm cutting because it relieves me. Well, doesn't it cause you any pain? No, I don't feel any pain when I do it. So then what's the purpose? Well, to relieve the pain that I feel inside because I really can't feel any pain. But if I cut myself, I can look at it and I'm bleeding. And I know that when people bleed, they usually feel pain. So something's happening. And it's also a great release. I feel that what's inside me is coming out. That's how deep this pathology goes. And they don't feel pain. That's the sad part because sometimes, especially the borderlines that cut the wrists, this way, they try it superficially, but unfortunately they cut it this way and wind up nicking the artery, and that can be fatal. Or this way and nick the artery, and that can be fatal. Or the ligaments and tendons in the wrist. You know, if you cut this way, you got the artery. If you cut this way, you got the ligaments and tendons, or you got both, and it could be fatal. Um, so these people are very impulsive, very, very impulsive to self-damaging. Substance abuse, big, 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 big on substance abuse. And they'll use the drugs to medicate the pain or to give them a feeling that they don't have, or even self-destructive tendencies. They'll overdose constantly back and forth, and they'll also use the substances for control. You're in a relationship, for example, with a borderline, and you're finding the relationship going south, and you want to leave the relationship, and you say, this just isn't working. I think you should see somebody else. Oh, you can't see somebody else? If you do, I'll just kill myself. I love you. I care about you. Oh my God, you can't do this. You're my everything. Well, I'm sorry, but I this is about me right now. I can't. I'm sorry, I've got to go. Bye, and you leave. And then all of a sudden, a couple days or a week or whatever passes, and you get a phone call, and phone number doesn't look anything that and it's a hospital. Hi, this is Dr. Jones. How are you? Is this Tony Scuderi? Yeah. Well, do you happen to know Susie Cupcake? Well, yeah, I know her. What's up? Where are you from, Doc? I'm from the General Hospital over here, the emergency room. Oh, what's going on? Well, Susie Cupcake tried to kill herself, and we revived her and all this, and she's okay. She's secure. We got her in a room. But she's been asking for you, and because you seem to be the only one that she knows. Do you have a relationship with her? Well, no, Doc. We used to be boyfriend and girlfriend, but we've broken up. It's been a couple weeks now. Well, she's really in bad shape right now, and she's asking for you. Is there a possibility that you can come down and talk to her a little bit? Let me stop there because now you got to make a decision. At this point, you're out of the relationship. So what she does, she does. I don't care what kind of relationship you've had in the past. It could have been very intimate or it could have been superficial. It's up to you. I don't care, you know. But even in the most intimate relationships, sometimes your impulses to return to that relationship is a bad thing. You've left it, you've left it. Leave it alone. It sounds cruel, it sounds horrible, it sounds neglectful. You're not a therapist. You're in the relationship. You have no commitment at that point once you leave that relationship. I've been in relationships, in the past where I've absolutely loved the woman, and what winds up happening is they dump me and I can't go back. Right. And I have learned in the past that when that happens, I feel the pain, it hurts. I just have to deal with the pain, leave it, and move on. Remember the good times, despise the bad times, but know that this is about me now, not about her or us. Because if I go back to that relationship and she takes me back, it's never going to be the same. That pain is always going to be there. And that can destroy a relationship. Okay. If you're not ready for the relationship, usually what happens is a mutual breakup. I think we just need to separate. Yeah, I do too. Let's stay in touch in the future, but it just isn't working. Yeah, I'm sorry. I really care about you. Yeah, I care about you too, but you know, okay, well, bye. And then maybe a couple of years later, perfect example of this is, the what's her name, Jennifer and Ben Affleck, right? Jennifer Lopez and Ben Affleck. They were a thing for a while, and all of a sudden they broke up. She gets married, she gets divorced. Years later, they get back together again. Now they're married. And they sit there and they both say we needed to do that. So, borderline clients can be manipulative and they can use substances in their favor. Um, they can be obsessive spenders, impulsive sexual users, abusers, um, binge eaters. Not that all binge eaters are borderlines. Some of them have a different illness altogether. That goes into anorexia and bulimia, binging and purging. That's not a borderline. It can a borderline can be, with that co-occurring disorder, of anorexia nervosa, but somebody that's a true anorexic and nervosic is not necessarily a borderline. Okay. But borderlines can use that. Um, Reckless driving, you know, maybe under the influence, maybe not, but they can be totally self-destructive. They can go into a very depressed state and just want to kill themselves. And we constantly try to rescue them. These can also be the codependents. The borderline is a codependent, you know. They have chronic feelings of emptiness that just don't seem to go away. The self-depreciation, the disliking of everybody, uh, they can be very, very, very intense in these emptiness feelings and self-depreciations. Um, Very intense anger, very intense people, and the anger is very inappropriate sometimes. You can be doing everything, and they just get angry. They push you away. And as much as you want to embrace, they push away. And then they'll apologize for pushing you away. And then everything will be fine for a while. Then you get angry again, push you back. And this is just a constant push me, pull you. They can have, they just can't control their impulses. Very poor impulse control, right? Um, Stress reactions. They can come, they can go. Sometimes they get overstressed. Sometimes they have no stress, very transient. Paranoid ideations. You don't like me. You never did. You're trying to kill me. You're trying to hurt me. Who do you think you are? All this because they're insecure. The paranoia comes from a lack of self-interest in them. And then you have the ones periodically that can have very, very severe dissociative disorders. We used to call this multiple personality disorder. We now call this dissociative identity disorder. Hearing voices, seeing things, having different personalities within them. This is something that the substance use disorder clinician cannot touch in any stretch of the imagination. Don't try to treat this. You're not qualified for it. You need special training for this. It's called dialectical behavioral therapy, Marshall Linehan stuff. It's really good. I use a lot of her stuff when I do individual therapy, even without borderlines. It works great. But if you know anything about Marshall Linehan and about her DBT stuff, she herself is a borderline. Recovered, yes, which is unusual for borderline. But her work is magnificent. She's got a wonderful book and a wonderful workbook that you can use. But you got to be careful with the borderline client. So if you get a borderline, run like heck. No, just joking. You want to feel like running, but don't. Um, Learn her material. Get training in DBT. They have workshops. They're quite expensive. But if you want to treat somebody, you're going to have to do this. But you're also going to have to get a license. You need to get your PhD in psychology or MFT or social worker or something like that. Don't try this as a drug and alcohol therapist. You can treat it superficially, but don't ever do this intensely, because what this will do, if you get a borderline, it will trigger your addiction, and it will get you to get your impulses of caretaking involved. And then once you hook up with a borderline, you start to caretake, you're going to find yourself in a lot of trouble very fast, and you may even have a lawsuit. Right? So please don't do that. Maintain your professional boundaries, because a lot of them can be very seductive. And as they start to seduce you in very subtle ways, you got to be very careful, because some of these relationships can overstep the boundaries and become very sexual. And if you have a sexual relationship with your patient, say goodbye to your career. Say goodbye to it, because if that gets reported to a board, you've lost your license, you've lost your credential, and if there's an application you have to do, and have you ever had any um, run-ins with any type of professional boards, and you put no, and you have, and they check the board can sit there and legally say that the person was let go. For why? The only thing they could say is for cause, and that's it. It's a professional board, and you can't sue the board for saying that. You did it to yourself. So be very careful. Assess the client's ability to tolerate stress. If they can't tolerate stress, they can't be in your group. And again, I go back to Medi-Cal. Medi-Cal doesn't care. They will stick them in group and sit there and say, especially in the clinics, you got to treat them. They're our patient. We got a contract with you. Treat them. And Medicare is right. Medi-Cal is right. Sorry about the pause. That little ding that you heard in the background was a phone message. So let me continue from here. Um, so as I says, understand that the client can't be in group. They just can't be in group. Um, and as I also said, Medi-Cal wants to throw them in group. Um, Unfortunately, if your clinical director or your supervisor says you have to have them in group, you got to have them in group. Um, the important thing, something that you may want to suggest to your clinical director or your clinical supervisor, okay, is that they hire a specialist that does DBT and just have a DBT group. Because if you're studying DBT and you're certified to do it, DBT therapists have group themselves to protect themselves. But other than that, they don't. Now, another nightmare that you may have is called the narcissistic client. Now, this client is very grandiose, and has an elevated sense of self. They think they are the most important thing in the world. And I'm going to tell you right off, one thing you don't want to do with a narcissistic client is attack their ego. They will destroy you, or they will try to find a way to destroy you. If I have time at the end of talking about the narcissistic client before I go on to the last slide, I'll tell you a situation that happened with me. Um, and fortunately, I won, but that's very rare. But they're very grandiose. They've got this very high sense of importance. If you are, they think that they can only relate to people of their caliber, and everybody else is junk. It's horrible. They have a preoccupation with fantasies of unlimited success, power, love, brilliance. It just, it's unbelievable. They are the greatest of the great on top of the great. And nobody can say anything against them. If they do anything, even if it's something in jest, oh come on, you really don't know what you're talking about, do you? You're done. I mean that is seen as an attack. They have such a fragile ego, such a fragile ego. Their boundaries are so loose. They have a belief that they're very special, and they can only be understood by other special people, and people with a very high status like they have, even if they don't have a high status. This type of person is the kind of person that will sit there and say, oh, I graduated from Harvard with honors. I've worked for 6 law firms as a good prosecuting attorney. I did a lot of work with drug and alcohol patients, I really don't need to work right now. I'm just doing this for fun because I'm really a millionaire. And then when you go back, they never graduated from Harvard. Nobody ever knows who the heck they were in the law firms that they talked about, and everything else is a lie. But yet this inflated ego to make them feel good. And the sad thing about it is they're also very convincing. They can convince people to do that. In fact, this is at the time of this recording, this is 2023. There's a senator that was just elected, and the senator is a narcissist. And this is exactly what he did. He embellished his resume, his work history, his school, his relationships, everything, his finances, the whole bit. He got elected to the Senate, or the House rather, got elected to the House of Representatives. He got into the House, and all of a sudden they started to do some searching on him, and everything was a lie. And now people want him out, but he's been sworn in. So now we've got this narcissist in the House of Representatives. This is how dangerous they can be. And this guy's a legislator, and he knows nothing. He never went to college, never graduated, whatever the case may be. This is what a narcissist can do. Okay, they think they're very special. They need excessive admiration. They can never feel that they are less than perfect because they feel entitled. They have the sense of entitlement, and that's it. That's it. Um, if you attack them interpersonally, they get very explosive. They will they will nail you. They will just act out. They have no empathy. They have no care, no compassion, no consideration, no conscience. You know, if they can get on top of things anyway, they will do it. We see this in oligarchs. We see this in presidents of countries. We saw this with a former president of the United States recently that almost destroyed our democracy. Oh, everybody. They're very arrogant people, very arrogant, very standoffish. They have a very haughty behavior, and their attitudes are very much um, negative and angry and agitated. And if they're in group, the narcissist will take over the group and they'll want to take your job. A narcissist will try to be a therapist in group. They'll sit there and they'll listen very carefully and they'll slowly manipulate. And then when somebody has an issue, you know how we share in group, right? We want to share with each other, we want to get the group involved. Oh, they'll share. They'll sit there and they'll just play therapist. Oh, John, wow, that's really something. How do you feel about that? Have you ever thought of maybe this? The same thing that you do, they'll do. Now, if you let them do that, say goodbye to your group because now they've just hijacked the group and took over it. Be very careful with them. Do not attack their ego, right? Even if they sit there and they seem like they're doing something good for the group, be very careful on how you accept it. I had a job one time. Here it is, right? In my example, I had a job one time at San Quentin State Prison, and one of the psychologists over there also taught at University of San Francisco in the psychology department. And he approached me one time, and I didn't realize he was a narcissist. Should have known better. But he was a very good guy and very good at what he did, and just sucked me right in. And nobody even warned me about this guy, right? And I was new, I was young, right at the time. And he says, "Hey, University of San Francisco is looking for a professor, part time. Would you like to? I could put you in touch with the dean." And I said, "Sure." So I got my interview, got the job, it was wonderful, and started teaching in the psychology department. And then the dean approached me one day and sat there and says, "Listen, we need you to teach a course in forensics. Would you like to do that?" And I said, "I would love to do it, but Dr. So and so has that class, and I don't really want to encroach on his territory." Oh no, he said that he wanted to go on vacation for a little bit, and we want you to teach this course this semester because he's going to be going away and we're going to be offering it. Nobody will teach it. I said, "Sure, I'll talk to him about it." It was okay. So I went into work the next day and told him, he goes, "Oh, yeah." He goes, "I decided I wanted to take a break. And I've got all the work material and this and that." He goes, "I can give you all the videos, tapes, anything that you need, the CDs, blah, 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 blah. And I said, "Well, thank you. If I need it, I'll get it." Great. So I went back to the dean the next day and says, "I'll take the class." Sure. Dean tells him. And next day I go back to San Quentin and I'm walking down the hall, with a chart in my hand, trying to think about what I'm going to do with this guy on death row. and I hear my name from him yelling at me down the hall in the middle of everybody. Who do you think you are? And then he berates me about taking this class that was his class. How dare I take it? Who do I think I am? I know how to handle you. I'm going to go to the dean and tell the dean that you stole this class from me. You have no right doing this. I'm going to fix you. I panicked. So I went back to the dean and I talked to the dean. And I says, "Well, I didn't realize this." I says, "If it's his, give it to him." I says, "Please, I don't want it if this is going to cause a problem." And she says, "Oh no, we want you to teach it. He's out at least this for this semester." Okay. Well, it got so far, he wound up writing to the board of psychology complaining about me at work. I wasn't licensed at the time, still not licensed psychologist. I decided to abandon that, become a licensed addictions counselor. I didn't need that headache. So he wrote to the licensing board, and the licensing board wrote to me demanding that I explain my situation. How dare I call myself a psychologist when I'm not licensed? So I went to the director of the mental health department in San Quentin, and he fixed it. But boy, let me tell you, I went through hell. This is what a narcissist can do. That's one reason why I just don't want to be bothered with crap like that. Uh, Understand that they're very oversensitive to criticism. Understand that you can't tell them they're wrong. You've got to tell them they're right. But don't be afraid to confront them directly. Just don't attack their ego. And if you do confront them, you need to confront a narcissist very carefully. Understand that a narcissist is really a very vulnerable person. They don't understand their vulnerability. They don't understand their sensitivity. If they feel vulnerable, they have to embellish it to hide it and to bury it. So what you want to do is you want to work with their vulnerability. And as you work with their vulnerability, you're teaching them that yes, they are good people, they're a good person, they know a whole lot, but they don't know everything. Let them teach you, you teach them as well, and you have a joined way of teaching. And that works. Again, if you, as the addictions counselor, have a narcissist, you do not want to handle this person. What you want to do is you yourself want to just send it off to supervision. Okay. All right. This is a long video and I appreciate you. I hope you broke it up, or if you had the time with a cup of coffee or something to watch it, great. Be very careful, and I wish you well, and good luck in your studies. Bye for now.